2 days. Well, I've still been sick actually. Oh, it's my intern, see? Well, not anymore, he's moved on from surgery. Anyway, I have had such a nice last 2 days. Yesterday was Anzac Day and I found out that I got on the Dean's Roll again for my results from last year. That's really, really nice. And then the day before that, I found out that I was one of the students nominated to go to Lund. So every year the Lund System Clinical School does a exchange program with Lund University in Sweden, and this year there were so many applicants that the students had to be selected by a panel. We had to submit 3 different references, 1 clinical, 1 academic and 1 professional, and we also had to write a page about ourselves. The selection was also based on our academic and clinical performance, so there was a lot that kind of went into it. So yeah, I'm just really flattered to have gotten a spot and really excited, and it's been a nice pick-me-up after I've been really run down and a bit unwell, so couldn't have come at a better time really. This morning, just continuing my placement with the upper GI team. In theatre this morning we did a mesh umbilical hernia repair and then a laparoscopic cholecystectomy, which was really good to see. Learned about Carlos?
Jack's just like, look like a Jack. Oh, you missed him.
We were quizzed on Carlo's triangle, which is made up of the cystic duct, common hepatic duct, and the liver edge, and the cystic artery runs through there, which needs to be clamped when you take out the gallbladder. And 2 o'clock now, and I'm grabbing a coffee and some lunch, decaf coffee and some lunch, and then I'm going back to the wards for the afternoon, and I need to prepare 2 patients for gram rounds tomorrow. And I've got a trivia night tonight to support one of the staff at the clinical school. He's also my friend, and that starts at 6 p.m, so it doesn't leave me much time to get these patients done. So yeah, wish me luck with that. And I might even have some caffeine in my 2 p.m. coffee. The theatre masks always take the makeup straight off my face. All that hard work gone.
This one flatbread for you and some hot dirt water.
And what we're gonna do now. How sweet in me. Trivia time. Uh-oh. It is Sunday and the AMSA intern guide is out. This document comes out every year, specific to the year, and it tells you all the information about the internships in the different hospitals across Australia. So yeah, I have a lot of reading to do. It is currently the 30th of April, and in Tasmania, intern applications open on the 3rd of May and they close on the 2nd of June. Most other states open around about the same time. New South Wales and Queensland open a little bit later on the 15th and 18th of May respectively, but they all close on the 2nd of June. So countdown is on to get those applications done, and we have to do an online application. We also have to ask our referees to fill out their portion of the application, writing about our suitability to be an intern. Actually, I have been working on my resume this morning, which is funny timing. It's all happening apart from me. I'm not happening. I'm definitely not happening. Hey friends, I'm going to give you guys a super brief, simple tutorial on gallstones because it's a really common surgical topic and it's pretty easy to learn a few different names about the diseases that they can cause. I put a few pictures together to demonstrate some of the basic anatomy and physiology, hopefully make things nice and simple if you're not familiar with the topic at all. Here we have the liver in blue and the biliary tree which drains the liver. We have the gallbladder also in green which connects to the biliary tree too, which ultimately drains down into the small bowel, specifically into the duodenum, the first part of the small bowel. I almost forgot about our little pancreas as well. So we have the liver, biliary tree, gallbladder, duodenum, and the pancreas. Now a little bit of physiology. Bile is produced in the liver, and we need bile to help us digest fats in our intestine, either for absorption or excretion. Bile is made up of water, some electrolytes, and its major solutes: bilirubin, which is a breakdown product of red blood cells, bile salts, phospholipids, and cholesterol. Bile is taken up by the biliary tree, and it can either be stored in the gallbladder or it can continue on, ultimately down into the small intestine where it mixes with food. In that distal part of the biliary tree, bile is also joined by the pancreatic enzymes that drain it, which help to digest our food too. Through a a part of the biliary tree which I forgot to draw earlier. Our body's major source of cholesterol is not actually from our diet, but from the synthesis in the liver. So that's why it gets transported as a part of bile down the biliary tree into the small intestine. Pathophysiology. There are 4 main types of gallstones, and I'm going to talk about the most common type for you today to demonstrate some principles, and that's the cholesterol gallstone. The mechanism by which these gallstones form, i.e. the pathophysiology, involves fancy words like supersaturation, nucleation, hypermotility, and so on. But essentially, excess cholesterol leads to cholesterol precipitation, and the cholesterol precipitation forms these stones. And this process happens in the gallbladder. So here is our gallbladder, and now we can see some stones. We can have little stones or we can have big stones, and this is relevant because that affects where the cholesterol stones go, which you'll see affects what condition you can get. We can already apply a medical word to just the fact of having gallstones, and that's cholelithiasis. Chole refers to bile and lithiasis refers to stones. So bile stone. For our first presentation that we can come across, one of these big stones in the gallbladder can push up against the neck of the gallbladder, where it becomes narrow and starts to transition into the cystic duct, a part of the biliary tree. This big stone will get stuck there. One of the things the gallbladder does is squeeze the bile that it's storing out whenever it's needed. When your stomach registers some fat inside of it, there's some signals sent to the brain, signals and hormones sent back to the gallbladder squeezes to release some bile to ultimately help to digest that fat. If that signal occurs when that big gallstone is sitting at the neck, the gallbladder squeezes hard on that stone, and you can imagine that causes some pain. This is called biliary colic. Biliary pertaining to our biliary system, i.e. our biliary tree and our gallbladder, and then colic because that means pain that comes and goes in waves. Pain comes when the gallbladder squeezes, and the pain goes when that stone ultimately falls back into the bigger part of the gallbladder, where it's got enough space such that when the gallbladder squeezes, it's no longer squeezing directly on that stone, and therefore we're not getting any pain. So that's what can happen with these big stones. Biliary colic. The stones go up into the neck of the gallbladder squeezes on it, you get pain, but then ultimately the stone falls back away. In our next condition, once again, we have one of these big stones going up to the neck of the gallbladder, but this time the stone actually gets stuck there and it doesn't fall back. Now when that occurs over a longer period of time, ultimately the gallbladder becomes inflamed. And this condition, when the stone is stuck there and the gallbladder is inflamed, is called cholecystitis. So chole, again meaning bile, cyst referring to the gallbladder. The gallbladder itself is a cyst, and itis meaning inflammation. Inflammation of our cyst that contains bile, i.e. the gallbladder. I'm not sure that's quite a perfect translation, but that's how I think of it. One moment, please. Found it. Alright, next, in this case, our small stones can actually cause even bigger problems than our big stones. If a small stone is transferred out into the common bile duct, that middle part of the biliary tree, then we have choledocholithiasis. Chole, bile. Doco, duct, lithiasis, stones. Choledocholithiasis can cause pain and it can cause obstructive jaundice, which I can talk about another time, but basically it blocks off the flow of bile down into the small intestines. So it backs up in the tubes, then up into the liver and back into the bloodstream. Ultimately, its particles can deposit in the skin and make you go yellow, i.e. jaundiced. Choledocholithiasis can also cause another really important problem, which is called ascending cholangitis. As a general rule in the body, when things are stopped or slowed down, this can cause problems because it increases the risk of infection. Instead of the natural flow of the bacteria being able to flush out any bacteria that might end up in the biliary tree, with this stasis, the bacteria has more of an opportunity to enter, stay, and ultimately multiply and cause an infection. And that's what the problem is with ascending cholangitis. Bacteria comes up from the bowel, it takes advantage of the lack of flow that the choledocholithiasis is caused by causing that blockage of bile. It enters the biliary tree, multiplies, and we have an infection. This can make the patient really, really sick. The symptoms of cholangitis are well known as either Charcot's triad or Raynaud's pentad. In Charcot's triad, you get fevers, right upper quadrant pain, and jaundice. Fevers come from the infection. Pain comes from, in the same way as biliary colic, we've got that tube squeezing on the stone. And finally, our jaundice, as I described before, is from the bile not flowing and backing up. In Raynaud's pentad, we have the 3 that I just mentioned, but in addition, you get confusion and you get hypotension. From those extra symptoms, you can see that the pentad is a bit more severe, and its association really emphasizes how severe ascending cholangitis can be. Next, if the stone gets a little bit further down the biliary tree, it can cause a blockage where the pancreatic enzymes exit the pancreas, and the back pressure on the pancreas can cause inflammation of the pancreas. pancreatitis. Pancreatitis can be anything from very mild to a very, very severe condition. So again, although gallstones are quite common and sometimes can just cause recurrent pain from biliary colic, they can cause very severe conditions in certain situations. The last one I'm going to talk to you about is not so common. I've shown the gallbladder sitting away from the small bowel in our picture, but in reality in the abdomen they can be much closer. There's not really any empty space in the abdomen usually. In some situations the gallstone might ultimately be able to erode through that gallbladder wall and then continue to erode through the small bowel wall. And in this situation we can get a gallstone ileus. And ileus means that the bowel has stopped moving, it's not working. There's lots of problems that can happen with an ileus. You can get excess fluid pulling into the bowel and so on. So that's an important condition too. Yeah, so here's my super quick tutorial on gallstones. I hope it was helpful for you. I'd really love to know if I'm pitching these tutorials at the right level. I started off using medical terms, I guess thinking that medical students might be watching this, but it also has occurred to me that people who are aiming to get into med school are watching these videos too, and so you guys would have never been exposed to these words, so I'm sorry if there's a bit of jargon in here. I'm kind of going somewhere in the middle here, giving you some medical jargon, because that's how they like you to talk in med school, and also trying to break the words down and make them a bit more simple. So yeah, let me know what you think if you like them. It is 3 o'clock on Tuesday. We're just down in the park. Aaron's just come home from helping out with the Cyclone Debbie disaster up in Mackay. So nice. So nice to have him back. I'm back on Unit 1 this week, which is breast and thyroid, and I was in theatre this morning. I'm just gonna stand here. Okay. I was in theatre for the morning. We did 2 wide local excisions and sentinel node biopsies for breast cancers. With the sentinel node biopsy, you inject a blue dye into the superficial lymphatics around the areola, and then it takes about 10 minutes, and that goes out to the lymph nodes if they're involved with a cancer. After that, we saw an infused port insertion for a man who had metastatic bowel cancer. I haven't seen one of those before, so that was good to see. After that, we went down to the wards and saw a chest drain removed from a guy who was mountain biking in Derby, and he had some rib fractures and a pneumothorax, just like in the trauma case that we saw the other day, but a little bit less traumatic. It's actually my last week of surgery now, so it's all ending in a few days. And then I'm jumping on a plane on Saturday morning to go away for a week. Last day. Today, done. After this, one more day. So much on today though. So much on yesterday. It's been so busy. Last day of surgery. Oh hey, last day of surgery. Get out. Last day of surgery. Done. I just went to vote actually because I'm going to the Northern Territory tomorrow and voting is tomorrow. And I've got a box of all my sutures and things to use. All my sutures and things to use in the workshop's gonna be great. I'm super excited. That is that. My last day of surgery is done. 6 weeks of surgery, and the last time that I will do surgery as a med student. It is 4:30 on Friday. I've just quickly jumped into town to vote, and I'm getting on a plane at 7 o'clock, and I haven't packed yet. I've got some sutures and things to take to the high school college students in the Northern Territory to do some workshops. I got to see a mastectomy this week and also a hemithyroidectomy. I went to the specialist clinic this morning, and I also went to pre-op clinic too. I also went to volunteer at AgFest yesterday afternoon, which is a big agricultural festival here in Tasmania. And then I even got to gym in time after that to teach our class at 5:15. From there we went straight over to my pop's house because it was his 29th birthday. Yesterday was pretty full on. Today at 1 o'clock we had another talk about internship applications from MDA, which was super helpful. A doctor from Melbourne came down to talk to us about the process, and he's a medical administrator. I think he works at the Alfred. Job applications are open as of 2 days ago, so I need to polish up my CV and get onto that. Right now I need to pack. I wonder how I'll go putting all these sutures and things in my luggage. I hope you guys have enjoyed the snippets I've been going through this rotation and learned something. Throw your questions to me down below in the comment as usual, and I will get back to you. See you guys. On the plane I'm gonna do heaps of video editing. I promise. I'm also gonna do my logbook.